Yeah, we're ready.
Ready. Carry on, Dr. Mariam.
Yeah. So good afternoon, hi everyone, and I would like to welcome everyone who's joining us today in our third COVID-19 seminar webinar. And today we will be focusing mainly on surveillance, test and trace and intervene of COVID-19. And before going in depth in this discussion, allow me to salute and greet all our colleagues who is in the front line, trying to save humanity and doing their best in controlling this outbreak as much as possible, with all the dilemma and different opinion and view from higher level like WHO till the minimum level when it comes to a physician in front of his patient. And today we wish and we hope that we will highlight all those hot topics where at least you will have a definite good answer from experts and people in the field from a different point of view who is serving the humanity again in a different part and different region in globally. Allow me in the beginning to extend a special thanks and on the behalf of the Arab Public Health Association. This webinar is under the sponsor of the Imperial College for Public Health. And I would like to extend a special thanks for them to allow me today to chair this session with an expert and a very senior colleague in this field. And I would like to introduce first our first speaker. We will start with Professor and Dr. Mohanad Al-Nsour. I think majority of the people in the Arab world knows this personality and his great impact in the whole nation and this part of the world. Dr. Mohanad Mansour, while he is serving specifically in public health and epidemiology, Dr. Nsour, he is a PhD. He got his PhD from Glasgow University, Scotland, where he was a fellow with the International Agency for Research on Cancer. And in the same time, he served the whole region in the Middle East. And specifically in his long CV, I would like to mention that while he's working at the Center for Research on Population and Health at American University, Beirut, Professor Nsour was analyzing the national data set, including data from demographic and health survey in Jordan as well and in Yemen. So with his experience and community field work, we would like to hear more from Professor Nsour, Mohanad Nsour, a brief about surveillance and what we do mean about it. Dr. Mohanad Nsour, allow me to start with a very brief introduction about our topic and how we would like to address it from a different point of view. At the same time that we comfort the current crisis, we must plan for a future to aim at, and to place to enhance our ability to conduct effective surveillance, containment, and case management. As the incidence COVID-19 decline, case-based intervention will again become an option. Building those capabilities now will enable us to move beyond the extreme and disruptive physical isolation measure in place across the globe. Every region globally aim for the following outbreak surveillance and response capability. First of all, test and trace infrastructure, capability for widespread diagnostic testing and data sharing to enable rapid case-based intervention. Secondly, syndromic surveillance, integration of the test and trace into an enhanced national syndromic surveillance system. Thirdly, serological testing, capacity to conduct widespread serological testing to identify reliable markers of immunity. Fourth, rapid response, capacity for isolation, contact tracing, and quarantine. So all our discussion will go around these 4 points, which is the aim and the core of surveillance system in the whole concept and the whole chain. Professor Mohanad Al-Nsour, the floor is yours.
Thank you very much, and good evening, everyone. And I am very pleased and honored to be part of this webinar. And allow me first to thank ArPHA Public Health Association for organizing such a very important webinars during the current situation that we witness in the region and the globe. And I extend my appreciation to Professor Salman Rawaf and Professor Tawfik Khoja for organizing this seminar. Secondly, thank you very much, Dr. Mariam, and appreciate your chairman this session. I would like to start my presentation. I'm working on just, I'm working on fixing it, but in general, my presentation is will focus only about the scientific background on the concept of surveillance, testing, trace, and intervene. And mainly my presentation will be focusing, on 4 dimensions or pillars. The first pillar is about COVID-19 surveillance. The second is contact tracing, general information about testing, although I am not expert in testing, so maybe I can skip it. I am epidemiologist. Then we will talk briefly about quarantine and evaluation and some experience from field epidemiology training programs in our region. So in terms of, in general, as introduction, on a global scale, COVID has affected almost every nation. Today, the number confirmed cases exceeds 7 million, with many undetected cases because of the surveillance ability and testing efforts are currently not detecting all affected people. Countries adopted variable levels of public health and social measures. As the cases decline in some of our countries, as the burden of public health and social measures, it became intolerable to keep isolated. Countries started to ease these measures. However, this requires a very robust surveillance system in our countries. I cannot see my presentation so far. Do you see it? Yeah.
Not yet.
So, Dr. Mohanad, go to the share screen. Go to the share screen.
Yeah, I am there.
Okay, and you will see your presentation. Bring it to the webinar.
Okay, sir. I am every day. I do this 3 times per day, but I don't know what happened now. Okay, so we will continue until fixing this. I'm working on it. But in general, as we know about the surveillance is continuous, ongoing process of collection, interpretation, dissemination of the information to take the action. In general, the overall aim of any surveillance, and specifically the COVID-19 surveillance, is to limit the spread of diseases and to enable public health authorities to manage the risk of the COVID-19 and its social and economic consequences. This is the overall goal of any surveillance. Specifically, we have...
Professor,
yes.
Are you able to manage to share your presentation?
Can we start? Maybe give me, maybe we can,
If you will go to the share.
Yes.
Okay. Yes.
Yes, screen sharing.
Yeah.
Yeah.
Can I? Yeah.
Yes, now.
Yes, now it's good. Thank you very much, Professor. Please go ahead.
Can you see it now?
Yes,
Yes.
yes, Professor.
Excellent. Thank you very much. Sorry for the interruption and accept my apology. Yes, so we are here. This is, yeah, we are here, and I was talking about the overall aim of our surveillance, which is to limit the spread of disease and enable public health authorities to manage the risk of COVID-19 and its social and economic consequences. In addition to this overall goal, we have specific objectives of COVID-19 surveillance, which are enable rapid detection, isolation, testing, and management of suspected cases, identify and follow up contacts, detect and contain outbreaks among vulnerable population, guide the implementation of control measures, monitor longer-term epidemiological trends and evolution of COVID-19 variants, and finally, evaluate the impact of pandemic on healthcare system and society. We need to keep in our mind self-surveillance help us to understand the co-circulation of COVID-19 various influenza and other respiratory viruses.
Yes.
Just in COVID-19 surveillance, we have to consider key considerations. The first consideration is to use, adapt, and strengthen existing surveillance system. And here the message that we need to send for all our colleagues in the region that we do not want to duplicate the system. We need to build on what we have in our countries. Secondly, implement immediate reporting where visible, conduct surveillance at different levels of the healthcare system, establish population dominator to aid in data interpretation, and establish lab testing dominators, ensure the existing surveillance of respiratory disease, such as LII, SARI, and maintain them. We have different type of surveillance, and here I like just to go through briefly about them. We are COVID surveillance system. We are working on individual and community surveillance, surveillance at the primary healthcare level, hospital-based surveillance, and mortality surveillance. In addition to these type of the surveillance for COVID-19, we should keep in our mind lab-based surveillance and integration surveillance. In terms of lab-based surveillance, while surveillance system will typically capture the number of COVID-19 cases, it's also important to collect information on the total number of lab tests conducted for COVID-19. The number of tests conducted and cases confirmed by different lab diagnostic methods used to be recorded. As I said, integrated surveillance is existing sentinel surveillance of influenza-like illness and severe acute respiratory infection, SARI, are very useful to monitor the trend of COVID-19 virus. So what I had explained, it's all about the structured surveillance. It's indicator surveillance. Now we move to other type of surveillance, which is event-based surveillance. Event-based surveillance is needed to rapidly detect any changes in overall COVID-19 epidemic situation. It's capture unstructured information from formal and informal channels like, all WhatsApp and other things, webinars and Facebook and other sources of information. Event-based surveillance requires the human resources to filter, triage, verify, compare, assess, and communicate relevant content. So what we have to do with COVID-19 surveillance data, three concepts that we need to consider in our mind. The first one is the essential surveillance data should be analyzed and reported daily basis with zero reporting. Secondly, data should be compiled either at national level or sub-national level. And finally, online dashboard to report daily surveillance data. We move to the second component of the today presentation, which is related to contact tracing. And here I like to just highlight a few concepts about the contact tracing. Contact tracing is the process of identifying, assessing, and managing people who have been exposed to the disease to prevent unwanted transmission. Contact tracing is essential to be conducted for all confirmed cases and may be desirable for probable cases in the absence of the comprehensive testing capacity as we see in many in our countries in the region. For effective contact tracing, it needs to be combined with testing and isolation. It cannot stand alone. Contact traces can be combined with door-to-door case finding or systematic testing in a closed settings such as residential facilities or with routine testing for occupation. Many innovative technology apps are available to contact tracing as we see in our region, Trace Together, Watan, Service, and other many apps applications that help us to contact tracing. But we have to highlight some of critical elements of implementation of contact tracing. These are community engagement and public support, careful planning and consideration for local context, communities, need and cultures, a workforce for trained contact tracers and supervisors, logistic support to contact tracing team, a systematic way of collecting and analyzing data in real time, contact tracing for at-risk and vulnerable groups. We should not forget that we have a lot of vulnerable groups in our region, refugees, IDPs, and other concerns about privacy and confidentiality. Contact tracing should be associated with security measures, should not be associated with security measures, immigrations issue, or other concerns outside the domain of public health. There was a debate in the region and elsewhere, about the workforce for contact tracing. And here I like to just to highlight a few facts about the workforce for contact tracing. Firstly, ideally, contact tracers should be from their own community. They should be familiar with and trained on the basics of COVID-19 transmission, prevention and control measures, and how to monitor signs and symptoms. Medical personnel should not be assigned to perform contact tracings unless circumstances required. And as we see, this is on the contrary of what we are doing in many countries in our region. Supervisors should be assigned to all contact tracing teams, cultural and social political context, and security concerns should be observed, maintain safety, adhere to the ethical principle of handling personal information and privacy. As you know, I like here to stop and comment about the privacy. This is one of the major problems in our region, that we know everything about the patients, about their names, families, where they are residing, what they are doing, etc. So we need to adhere to the ethical principles in this arena. Testing, I will skip testing. I think my colleague will talk more and better than me in testing, since I am not expert. But
Professor
and I like to move.
Professor
to
Mohanad, you have
slide about quarantine.
You have 5 more minutes. You can elaborate any point you would like to focus on.
Yes, Dr. So I like to clarify quarantine and isolation. Quarantine of response is restriction of activities or separation of persons who are not ill, but who may have been exposed to an infectious agent or disease, with objective of monitoring their symptoms and ensuring early detection of cases. However, isolation is different from quarantine, which is the separation of ill or infected people from others to prevent the spread of infection or contamination. Testing followed by contact tracing and isolation of those with positive test results has been applied by all countries that have been managed to keep COVID-19 virus in check. And this is what we keep saying, testing, contact tracing, isolating, and treatment. Current estimates of basic reproduction number of COVID-19 are around 2 to 3. To bend to the epidemic curve downwards, which will be only happen once effective reproduction number, RO, is low or is below 1. Persons with a positive SARS-CoV-2 virus test result need to be immediately isolated. And duration of isolation, you know, this is matter of discussion now in our region. Duration of isolation virus, but commonly about 14-day period of precautionary isolation. Repeated testing during this period can reduce it. You know, just a few words about field epidemiology training program. You know, many programs had been established in many countries in the region. As seen in the slides, we have more than 10, 11 programs in different countries. These countries with different level like advanced, intermediate, basic, were heavily engaged with COVID-19 response. The beauty of these programs that they are part of the ministries of health. They belong to the ministries of health. They are owned by the Ministry of Health. So the country in this outbreak, they totally rely on themselves. So they were a core milestone, you know, to COVID response in addition to rapid response team. These are some of their contribution at the region level, where they are doing outbreak investigation, tracing, and other things, as you see.
Excellent.
Finally, I would like, with the current ease of measuring, I like just to focus on about the importance of surveillance system must be enhanced to manage COVID through community-based, event-based surveillance with innovative ideas, approaches, tools to strengthen surveillance capacity. Comprehensive integrated national surveillance, a new dimension of privacy and ethics should be considered in our region, minimize the role of FETB, maximize the role of FETBs and field epidemiology in COVID response, and finally, periodic evaluation of COVID-19 surveillance. Thank you very much.
Thank you very much, Dr. Mohanad, and thank you very much for a very informative introduction and about surveillance, and especially focusing on the privacy of the patient with a whole new era where technology can be with two sides, where we can use it in detecting the cases and follow up, but in the same time losing our privacy. And I do agree on the concept where to emphasize on empowering the healthcare providers with continuous training program, which usually centralize under the umbrella of Ministry of Health, where you can make sure that you can trace them and generalize the service. Thank you very much, Dr. Mohanad, and we will be focusing in other points in the discussion, inshallah. Thank you, Dr.
Thank you very much, Dr. My pleasure.
Allow me, and I would like to welcome whoever joined us just now to continue in this lovely webinar, very essential one, where we are talking about the surveillance, test and trace and intervene in COVID-19. So now we will go with our second speaker. Allow me, and it's my great honor to introduce Professor Howe. Professor Howe is an interim director of public health for Westminster Council. Professor Howe, he mainly focused on bringing stability and leadership to the public health team, reviewing and putting in place a new team structure, and developing and recruiting to new posts, supporting the public health response to Greenfield, and ensuring financial control. And we know how essential these three elements are when we talk about sustainable, continuous healthcare services, especially from public health point of view. Professor Howe, welcome to our webinar, and we would like to hear more from your end, specifically helping us to identify what is the difference between all type available tests, and especially when we talk about how sensitive and specific are they when it's come to diagnosis and surveillance system. Floor is yours, Professor Howe.
Thank you so much for your invitation tonight, and I'm delighted to join you. As you say, I'm a previous Director of Public Health in England, both in northwest of England and more recently in London, and now I'm supporting the work of the testing and contact tracing with Public Health England, particularly in London. And thank you for asking me to describe how testing and contact tracing is being implemented in England. And I will touch on, as you say, issues around testing. So as context, it's worth saying that in England, contact tracing and testing was deployed just on the first few hundred cases back in early March during what we would describe as the containment phase. We went into what we call the delay phase on the 12th of March and introduced, like most places in the world, the key elements of social distancing, hand washing, stay-at-home guidance. And since then, those have been the mainstays, along with testing of our approach to COVID. I should say, just picking up on the last speaker's slides, that the R rate at the moment in England is thought to be somewhere between 0.5 and 0.9, though it does differ in the different areas around the United Kingdom. So testing started to increase about 2 months ago, and now in England there are about 200,000 tests done every day. And contact tracing started just 12 days ago. So we were at a reasonably early stage of mass contact tracing. We don't yet have an app for our smartphones, and we are hoping that will be introduced shortly. Clearly, that's going to be invaluable, particularly around proximity monitoring. So we look forward to seeing that in the UK. I thought it would be useful to start by describing the user journey and take us through testing and contact tracing in that way, very much building on the principles and ethics of the slides of the last speaker. So in the UK, when people have symptoms of COVID-19, they're able to order a test either online or by calling a telephone helpline. And similar to most countries, the three main symptoms are persistent new cough, fever, or a loss of sense of smell or taste. And either of those three will allow you to enter the system and order a test. At that time, people with symptoms must isolate for 7 days, and all their household contacts isolate for 14 days, as we've just heard. The tests itself are carried out at regional testing centres throughout the UK. They're mostly drive-through testing centres, although there are a few walk-through testing centres being developed. In fact, the majority of tests now are done through a home delivery process, where after ordering your test online, a courier will bring a test to be done at home, and then a courier is used to get it back to the laboratory. The turnaround for tests, the time taken from taking the test to the result being available, it is around 48 hours, or that the aim is to keep everybody's test result to 48 hours at the moment. I think there's a real ambition, as we've heard from the previous speaker, to increase that. It's absolutely, of course, crucial that the turnaround time is as minimal as possible. So certainly we would be aiming, I think, for at least 12 to 24 hours. Like you, I've heard of tests being available in 20 minutes, and that would certainly be a step forward. Special testing arrangements are, of course, in place in hospitals, both for staff and patients, and arrangements are also in place for nursing and residential care homes for older people and for employers of key workers. What I've mostly been talking about, of course, is antigen testing. And there are a number of different tests being piloted. And I'll come back to antibody testing in a couple of minutes. So that was the early stages of ordering a test. Thinking about then what happens if the test is positive. So if a test is defined as positive, then the person testing positive will get a text or an email or a telephone call with instructions on how to share their details of the close contacts that will require contact tracing. And contacts here are defined as people and places visited in 2 days before the onset of symptoms and 7 days since the onset of symptoms. And it's really defined as a contact within 2 meters of you for at least 15 minutes. And the contacts will be told that they have come into contact with an infected person, but will not be told the name of the infected person or any other details. And that is very much in line with what we've just been hearing about privacy and data security. The contacts then will receive a message to say they must self-isolate for 14 days. So do not go out of your home, and they should get a test if they become symptomatic during those 14 days. If the household members of a contact, they do not have to self-isolate, but the household members of a contact do have to self-isolate if the contact becomes symptomatic. So quite a lot of good communications needed, both with the cases and the contacts in the event of a positive test. And there, of course, is a lot of publicity now and national, regional, and local communications to get these messages over. So the systems that will make this happen are twofold. So when someone is test positive, and they've ordered it through the website, they can complete all the information regarding their contacts on the website. And it's entirely automated, and there is no face-to-face contact or any call contact. And we anticipate that over half the cases in England will use this website. So there won't be any requirement for any other activity. For those who can't use the website, and of course we appreciate particularly older and more vulnerable people, people who don't have mobile phones, people who are socially excluded, won't be able to. And they are called by telephone call handlers. And there are currently 24,000 call handlers now for England. Now, clearly, those specialist call handlers come from a variety of backgrounds and certainly aren't expert clinical professionals. But there is an expert clinical professional tier who, like most countries, are expert in routine contact tracing and infection control for measles or salmonella outbreaks or other infectious disease outbreaks. So we have a specialist team in all different regions throughout England who focus on those complex cases or outbreaks in care homes, in prisons, in schools, in hostels, amongst the homeless. So there's quite a specialist team who do that. Just a couple of other things to mention from my perspective, and it builds on what we've been hearing about surveillance. So yes, there are a number of surveillance projects, sentinel sites in primary care. Now much work going on amongst hospital staff and other caring professionals to build that picture of the epidemiology of this disease. The data that we collect from all of these, from testing data and contact tracing data, is of course critical to inform local action. And I think we're all now completely focused on the main prize, which is to intervene early on what we believe to be a new community cluster. There are separate arrangements for hospital clusters and care home clusters, but for community clusters. And the way and because the contact tracing is relatively new, we're looking at how we get the data to inform that. So at the moment, our local government councils receive daily updates on the number of tests, on the number of contacts in their area, on the postcode, so quite specific regional information by person and postcode for each case, which will allow quite focused and targeted action, working with our local directors of public health. So in London, for example, population of 10 million, there are 31 councils, and each one has a local director of public health who runs a local public health team. And their job will be very much to focus on those local communities, particularly schools or care homes or workplaces, to intervene early, work with local communities. And as we heard, the importance of community engagement at local level is central. And that is our area of focus at the moment. And with that, every local council working with Public Health England is developing local outbreak plans, building on what our field epidemiology services and epidemiology can guide us to where we need to work. And just a final note on antibody testing. So this is very much in development, as I'm sure it is in most places of the world, because it really isn't something that can be used for workforce planning. It's more in the UK being used for surveillance purposes to understand how our infection has spread. And we are very clear with staff and patients that although we can say that there has been an infection with reasonable reliability, and I'm sure we'll pick that up in questions in the panel session later, we can't use it to do any form of workforce planning or to guide use of PPE. So the fact that somebody might have had an infection isn't helpful, and we still need to protect them until we understand much more about the virus and how it has spread, particularly in the workplace and particularly in clinical settings, of course. So I think my final point really is that we're working like I'm sure most countries in rigorous surveillance, but using that surveillance to target local action. Thank you, Chair.
Thank you very much, Professor Howe. Exactly 15 minutes. Thank you. So thank you very much once again. And we can see, Professor Howe, for your experience and the guidelines and the criteria which is implemented in United Kingdom, the different approach globally, and that's all based on the resources and the infrastructure available and different demography of the high-risk group within each community. And specifically, we can see the role of technological tools that help increase the efficiency of the surveillance system itself. And I think there is too many lessons to be learned for, God forbid, in any future outbreak. Thank you very much. And there will be more questions, Professor Howe, in the discussion. Allow me, dear colleague, to introduce now our discussion panelists. And I'm sure all of you are very familiar with these names who are a reference in public health in the Arab world. And I would like to introduce Professor Salman Rawaf. and he is the president of Arab Public Health Association, and along with Professor Tawfik Khoja, who is the vice president for Arab Public Health Association. Please, Professor Salman, the floor is yours.
Thank you very much indeed, Dr. Mariam. Thank you very much, Dr. Mohanad and Dr. Andrew. Excellent presentation, superb background for our discussion. So far, we received a truly good number of questions from colleagues who are on YouTube and also through the email. I think one of the key elements which is coming from the two presentations, we shifting from some national approach into much more local approach. And I think Dr. Mariam alluded to the use of technology, possibly at local level among the people. There are huge concern among the population, huge concern about whether I have the infection or not. If I have the infection, am I actually protected? Am I going to be a free person? I can wander around. What is the probability of second infection? Because there are a lot of misinformation, as you know, around the world. And unfortunately, I would say 90% of the misinformation coming from our colleagues, the clinicians, either part of deliberate act, which I'm sure there are very few, extremely low number, but majority out of ignorance, because people, they want to pretend that they know and they simply put an idea or reflect from experience from other infection or other viruses or something like that. Not knowingly that actually this is a new virus and a new dynamic. And I'm very glad, Andrew, you highlighted this fact that we are still learning about the virus and how to interact with. So what are the views of the panel? And I want Dr. Mariam, and also I should say that welcoming Dr. Faris Al-Lami, Professor Faris Al-Lami from University of Baghdad, College of Medicine. I invited him to join us on the panel, and I'm delighted to have him with his experience. So I love to listen to you about these concerns, and will these tests and surveillance will address it? Should I go and buy a antibody test from the private sector, as many people are doing, get a peace of mind and paying $100 or whatever it is? To you, over to you. Andrew?
Yeah, sorry, I was on mute, forgive me. Yeah, it's a very interesting questions there. So what I didn't say earlier was that, and I wonder if this is reflected elsewhere, the test positive rate at the moment amongst symptomatic people is about 1%. So there are an awful lot of other viruses circulating, as you would expect. So therefore, and I think that influences how we think about this. That either we've scared everybody to want to get tested, and in the right, well, of course we need the information, but therefore, when do we act, and how do we act? I think the antibody testing is a very significant issue. And of course, the worry is that a lot of private sector companies are buying antibody tests for their workers without understanding the epidemiology of this. And although the market in the UK isn't flooded with antibiotic tests, then we need, we were really relying on the epidemiologists and the scientists in the UK to help us understand this. There's a lot of questions in the UK about repeat testing. Should we be repeat testing in care homes every week, every 2 weeks? Will that help? And the answer is we don't know. The sensitivity and specificity is also an interesting one. We hear, don't we, that there's a sensitivity of antigen tests is perhaps 70%. So quite a lot of false negatives there. And what does that mean, particularly in healthcare workers and allowing care workers back into their jobs? And that is something that we're very much cited on and helping colleagues think through. The antibody tests, I, like you, have read so many different reports and a number of the ones in the UK are said to be almost 100% sensitive and perhaps 90% specific. And I think we await further tests on that, I think. I'm not sure that the size of the trials warrants the confidence in those results. But even in something like this, even if it is 99% and it's used amongst 60 million people, for example, in our country, then there is also still a lot of false positives and false negatives. So I think we've got a long way, certainly in my country, to think about how we use these tests. Thank you.
Thank you, Andrew. Dr. Mohanad?
Professor, yes.
Thank you very much. Just I'd like to highlight that the importance of, since in our region we are in less developed countries, and the money and resources plays a lot of role to decide whom we can test. What we are hearing now in the region, that we need to test everyone, symptomatic, asymptomatics, pre-symptomatics, and with symptoms. I think for many countries in the region, irrespective to the sensitivity and specificity of the test, but I am talking about the resources, how we can better use of our resources. Are we going to focus on cases, contacts, and maybe to talk about probable cases, but we cannot test everyone. I think what we are seeing nowadays is attempt to expand the number of tests, but without any strategic plan in our region. So recently, many recommendation, and I think it's very important to consider that we need strategically to prioritize to whom we can use this test, and to not use it haphazard because the resources are very limited. This point should be considered for our developing or less developed countries. Thank you very
much. Professor Khoja, any comments?
Yes. Professor Khoja, unmute, please. Unmute, Professor Khoja. Unmute.
Professor Khoja.
Yes.
Unmute.
Yeah.
Any comments?
Yeah. Thank you so much, both of you. It is really interesting to listen to both presentations. I have 3 practical questions. One of them is about testing is already mentioned. The other one, maybe Dr. Mohanad and Al-Nsour. As you mentioned, we are in the comparing the low-income countries, the middle-income countries with high-income countries, even high-income countries regarding the contact tracing. And I really appreciate the comprehensive approach about contact tracing you mentioned. But will we need to adopt, with limited resources we have, a high-risk approach? I mean, prioritizing our approach for contact tracing, or is there any scientific approaches for our countries in this regard? If you see Saudi Arabia, they are doing huge approaches for contact tracing. What about other Arab countries, especially in countries with unstable countries? So I would like to hear from you a practical approach regarding contact tracing. You mentioned very scientific approaches, but now what's the practical approach in real life? Thank you so much.
Thank you very much. If you, the chairperson, allow me to answer the question.
Please, Professor.
You know, I am very practical and realistic person. If we go back a little bit before COVID-19, and I remember after Ebola outbreak, we did, and you know, the country did, you know, some sort of evaluation about our readiness, preparedness, and response for any forthcoming outbreak. And the results of that evaluation at that time, it was conducted for all, you know, majority of the countries in our region and elsewhere. It showed that we are behind, we are lagging behind. We have very different problems, even you know, before our preparation for COVID. So the current situation in the region and before the COVID is not optimal. So this, you know, lead us to build on that. Now we are talking about contact tracing. You know, with the current situation of the surveillance system for different countries, allow us to find the best modality for contact tracing. And here I would like to say that in many countries in our region, the contact tracing is still not very well established. It's attempt, you know, that we are going to the case, we trace the case, etc. It's still, you know, we are at the beginning. We are not doing, you know, different, many countries, you know, they are doing much better on contact tracing. They use information technology, they have their application. In other countries, still it's on hand or on job training done. The main thing with contact tracing, you know, to use, you know, very systematic approach, and to use, it's not matter only of collecting data and tracing. It's a comprehensive approach, how we can link the contact tracing with surveillance, with data management. Keep collecting without interpretation or without analysis of this information is a problem. I saw in many countries, I can say they collect, but what else? After collection of this information, who's going to filter, who go to classify, who's going to analyze, who's going to interpret these collections? So I think, Professor, and this is my personal opinion, that still we are in many countries lagging behind this. Many other countries, you know, they are doing much better than others, but still we are not applying the concept in the way that is clear for all of us. Thank you.
What Professor Lamy, maybe he has Dr. Salam.
Salami. Thank you.
Yeah.
Thank you so much for the colleagues who present the very great presentations indeed. And thank you, Dr. Salman, for putting this very hot topic indeed. That's a matter of the issue of the contact tracing and testing. These are very crucial, and they are the pillar of our public health practice in COVID-19 combating activities. I will be very direct to respond to the question. And honestly, probably one of the benefits that we had in Iraq and many other countries in the region is to develop some cadre from different levels to build the field epidemiology. And as Dr. Mohanad presented in his last slide about the tiers of public field epidemiology in different countries, including Iraq. And we had trained something like 150 individuals at the baseline level, at the district level, and we have some others who are still in the intermediate, and we have something like 9 cohorts of advanced field epidemiology graduates who are currently, they are run the field work in the majority of our governorates in Iraq indeed. So we were lucky indeed to have those people who are doing the job. So what they did really is they create teams responsible for the contact tracing, and this is at the level of the DOH, the Directorate of Health, I mean at the governorate level, and at the district level as well. And they go and test and to identify a complete list of those people who can whom the patient may come in contact with them. But honestly, this is not very comprehensive. To say the truth, they are mostly concentrated on the close family contact, not very close contact, but to a certain extent, those are who are close in the work, for example, or probably in some other settings where there is really close contacts and they are known, but they are not looking for exactly the 14 days and who come in contact and who fulfill all the criteria of close contact that had been presented by Dr. Mohanad and according to the WHO system. No, this is mostly we are concerned. So probably this is one of the gaps that we are detecting only part of the close contact, not all the close contact. And this is there is a possibility here that there is there is a possibility of transmission to others, and maybe behind the recent exacerbation of cases in Iraq. I hope we will have the opportunity to talk a little bit about testing in the coming questions, hopefully, and sharing the experience of Iraq in this regard. Thank you, Madam Chair.
Yeah, please, Professor Alami, can you elaborate more on this point about the testing and screening in Iraq? Very briefly, in 2 minutes, please.
Yeah, sure. Honestly, to start with, first of all, we have the Central Public Health Lab in Iraq, and we have the public health labs in all Iraqi governorates. And honestly, at the beginning, in the very beginning, we have only one single laboratory who did the job in Iraq, which is the Central Public Health Lab. And the kits had been provided by WHO at the beginning, and later on by the Chinese government. They sent some kits. They already had the PCR and so on. We started with one single laboratory, and by today we have 20 laboratories across all Iraqi governorates, and they are having a lot of the machines and kits and continuous procurement from WHO side, from Iraq governments and others. Probably we have a big problem here, which is the issue of the antigen antibody testing. Honestly, I personally was very optimistic of having a reliable antibody test, just like what we did with the majority of infectious disease that we are dealing with, so we are thinking of having some efficient, sensitive, specific, rapid antibody test in order to identify what proportion of Iraqi population, for example, they are infected, because as we all know that there are some people who can capture the infection asymptomatic and remain asymptomatic. Some of them would have very mild symptoms that he didn't even need to consult or to attend a health facility. But unfortunately, it was a full failure. I will say that this was a full failure. That's 250 rapid tests had been procured, and it was disseminated to all Iraqi governorates. And we try to use some sort of a system of active surveillance. That's besides the close family contacts, we used to go to the home surrounding, the family surrounding the case, and to identify if they have symptoms or not. And then if they have symptoms, they will be tested by the rapid test. And if it is positive by the rapid test, we will switch, IgM, we will switch into the PCR. But unfortunately, the yield was extremely low. Very, very disappointing, and honestly, that's to the extent that we are currently now thinking of not to procure the remaining amount that we already make a contract about, which is something like 1 million, because it was not of value, honestly. I would like to highlight this issue because it is very, very hot topic. And although everybody, I think in all the countries, they are thinking, and they are interested to see what a proportion of their community they are currently infected, in order to see the progress, how things are going. Thank you, Madam Chair.
Thank you.
Thank you.
We have, Dr. Mariam, we have a lot of questions from Dr. Samar Abdel-Noor, from Dr. Yahya Al-Khalidi, from Dr. Naim Al-Qasir, from Professor Namir Tawil, and so on. I'll mention the names as it comes. I mean, before we take some of these questions, there is practical question, and I think Dr. Mariam and Professor Tawfik, both of you are primary care doctors, as well as public health and genetic, etc. Why primary care did not do the testing or the center of the testing? Why it was done in location which is not immediate as the primary care center? I mean, that's a question which is raised by many people, actually, from primary care and as well as the public, saying, why should I go to drive for 5 miles when my primary care center only 200 yards away. Andrew, any suggestion?
Yes, so that's an interesting point, and we are in England looking now at whether people can get tested in their primary care centre. The issue, though, is that for the routine arrangements for an outbreak or infection spreading in the community are not ever through primary care. It is led by a specialist team of public health experts. And one thing we've been really clear about throughout the outbreak is please do not go to your primary care centre if you are infected.
Yeah.
Stay at home, wash your hands and keep socially distanced. So one of our biggest challenges, in fact, is thinking about, particularly in England, thinking about people who haven't got cars, because this whole idea of driving off to a centre or getting your partner, husband, wife, whatever, to drive you to a centre, remain in that car while you're having your test posted through the window, it is a very COVID secure way of working. Going to a primary care centre is certainly not.
Yeah.
And that's what's changed the thinking here.
It's a very good explanation. Thank you very much. Dr. Khoja, Professor Khoja. Yeah, I'll come to you, Dr. Professor Khoja. Any views from primary care?
Yeah, I think Saudi Arabia is a good example in this regard. They started in this issue, and I think one of the reasons, as Dr. Andrew is mentioned, is the cost of the test and also the experience of the people who are using the test. This is very important. I mean, you need people who are expert in this issue and trained to do the testing. It is not easy to ask a simple, an expert person or prepared person in the general practice to do the testing without proper training and proper preparation. So this is an issue. Second, that COVID is coming as a disease is coming as a sudden. And people in the primary care are trained on surveillance, on tracing contact, not on doing the testing by itself. So this is the issue why it's not a nationwide use as a testing. But Saudi Arabia, in the start, and I think until now, they are doing some center in the primary health care.
Okay.
Yes,
This is without fear of spreading the infection, as Andrew said. One of the reasons United Kingdom this was not allowed is simply to protect the primary care to continue with the essential services. Dr. Mariam, I know you are.
Yeah, I have another comment, Dr. Mariam, with your permission. So they also they went also to the communities to do that with specialized trained people. They went in the interest of Mecca and Medina. They put a special premises and they built special premises in order to do testing, and in area where they feel that it is highly susceptible cases, they do field testing with expert people. So what I mean that so they do so many approaches, but at the end you need to look for the cost and you need to look for the safety and preparation of people and the readiness of the people for such testing. Thank you so much, Dr. Salman.
Thank you. Dr. Mariam, your opinion on that? Your experience?
Yeah, in United Arab Emirates, again, it's almost the same concept, the way it's going in UK. But in the same time, as you know, the primary healthcare in the first period of the outbreak, it was the first point where the people from the neighborhood can go and outreach for a very cold cases. And here we were focusing mainly on a high-risk group, the elderly in our community. So in the beginning, primary healthcare was the only available services for them. As the secondary and tertiary,
this is for diagnosis, for diagnosing cases.
Yeah, to be able to accommodate the critical cases. And in the same time, what happened in United Arab Emirates is very well known that, alhamdulillah, we have a very excellent support from a decision maker. And it is on point. If our leader would say that we need to support, we don't consider so much about the budget. So a whole center will be formed within 24 hours. For example, in United Arab Emirates in Abu Dhabi, we had a full set of a lab which was built within a week to be able to accommodate all the screening throughout the UAE. At the same time, it's applicable for all the United Arab Emirates. The 7 Emirates were equipped and empowered with high-end center for screening as well as first respond. And the primary healthcare, as Dr. Tawfik mentioned, it was from the beginning not accommodated with all those skilled and expert people to front with critical cases. But I think from the whole exercise of this pandemic, and in my opinion, I might have a different opinion than my senior and expert, it's only a different opinion. I believe as much as possible, we need to screen population, because I'm talking about a United Emirates point of view. This is a time where the decision makers are supporting us with a huge amount of funds globally as well. And with the smart technology, with all these available data, we will not only identify the antigen and the antibody, it's a whole information, a big data where we will be able to elaborate other aspects related to humanity and related to genetic and epigenetic and different ethnicity. And that was very clear when we come to identify how specific and sensitive is the test when it's come to different mutation and type of virus available regarding the DNA mutation itself. And we can learn, again, this is a whole exercise for all the human beings. COVID-19 is disrupting all the routine and standard approach for surveillance or any health intervention when it's come to an outbreak and pandemic. So in my opinion, I believe we as a healthcare provider or a decision maker should take this opportunity to utilize whatever is available as a tool in diagnosing or upgrading the service for, God forbidding, any future pandemic or health crisis in locally or regionally or internationally. And specifically, Dr. Salman, in my opinion, the whole exercise of screening, having a new approach, different criteria in different parts of the world, this itself will be a very excellent resource for research, for coming up with new guidelines. And I believe it will be a good resource for WHO. And in my opinion, humble opinion, I believe WHO should be, somebody should come and shake it very well, where we will make sure at least those people will be settled and who's able to hold to the whole new challenges in healthcare system. So in my opinion, what is going on and the screening which are covering symptomatic and asymptomatic, it will be a great resource for future research and for new guidelines and for a new era of healthcare services when it's come to a public health point of view.
Dr. Mariam, you raised many questions in your answer. I'm delighted to announce now that next week we have 2 prominent colleagues from WHO, IMRO, and Geneva joining us talking about health systems during and post-COVID. Dr. Matariya, the Director of Health System and Universal Health Coverage, and Dr. Ed Kelly from Geneva. I invited both of them, Professor Khoja and I invited them, and we look forward to have them with us next Wednesday. So this is a small advert. But you raised one issue, an important issue about the role of primary care. And I think Andrew's answer was very clear. Let me listen to Mohanad and I'll come to the questions here. Dr. Mohanad.
Thank you very much. Just I have 2 comments, if you allow me. First one, I don't want to go back to the test, but I like to share with you some concern that happened in the region with PCR. You know, countries kept doing tests, but we need the capacity to test, to analyze these samples, you know. So we ended up with the countries that collect a lot of samples under the title of testing. Yes, okay, we can collect the test, but the question is, are our countries are able to analyze these tests? This is one concern. Second, I am so unhappy was, you know, to see during this outbreak the role of primary healthcare centers in many countries in our region. You know, I am sad to say that until even before 2 weeks, many countries, the primary healthcare were closed. So there was no any role for primary healthcare. This lead us, you know, lead us to talk more about the really what the role of primary healthcare, where we are in reality in terms of this capacity. We are talking about primary healthcare, you know, primary healthcare, public health, etc. But when the outbreak came, we felt that many countries in the region, they locked down their primary health cares, comprehensive health cares, and the primary health care. So this is, I think, something, Professor Rawaf, we need to stop on maybe for another scenario. This is, you know, something that we should not pass like without any in-depth understanding what happened in our region. Thank you.
Actually, we published the paper.
Yeah, I saw the paper, yeah.
Accepted now about primary care across Europe. Primary care across Europe, as Andrew mentioned, was protected. It's business as usual, but we didn't allow suspected cases or people with symptoms going direct to primary care center, but we asked them to call their primary care center and receiving advice. That was supported also by a national line, which is people should call 111 if they need it. I'll come back to this point, but there is an important set of questions. I'll come back to you, Professor Khoja. Let me take the audience.
But in this connection issue, I think we should not blame the primary healthcare situation in the Arab region or in the world by itself, because the sitting scene of primary healthcare, the tradition was not to test infectious disease in the primary healthcare. This is we trade in this business. In UK, I am British oriented, trained in UK for primary healthcare and family practice. In Saudi Arabia and Jordan, the setting of the primary healthcare is not for testing infectious diseases. It's for surveillance, tracing, monitoring, home visit, and so on and so forth. So to blame the system, I think this is totally wrong. I think we need to revisit the primary healthcare again and to see, is there a role of the primary healthcare in situation of epidemic in testing? This is very crucial issue. And second, that what you have raised really, Dr. Al-Nsour, is the crucial issue that we have so many tests in the lab and we have low, a few people who are trained to give the answer. So this is a big issue, not only in Saudi Arabia, all over the globe. Thank you so much.
Okay, actually, Professor Khoja, nobody putting any blame. They simply describe the situation. Yes. This is describing the situation, not a blame. There is a question from Dr. Yahya Al-Khalidi. What is the value of mass screening and its cost effectiveness? Anybody want to chip in? Yeah, Dr. Mariam?
Yes. Again, Dr. Salam, from being a molecular biologist as well, being in the lab, we know that when we talk about cost effectiveness, as much as test you have, the price will go down. So if we talk about cost effectiveness, more screening, more number of tests, less when it comes to the cost. This is from cost effectiveness. But from a public health point of view, again, this is a whole new exercise. We are learning from it. And I think it's too early to answer this question, in my opinion, how effective it is, the mass screening in this stage.
Thank you very much. There are, Andrew, I'll come back to you, but let me fire this question, which is specifically for you from Professor Al-Tawil about what is the validity indicators of PCR and a blood test, antibody test, and which blood test is more valid in your opinion?
I am afraid I don't have specifics on that. I mean, I said earlier that they're looking in England at all of the different tests to work out the specificity, sensitivity, and validity. And I don't have those figures to hand. I mean, I think that really takes us back to the issue of mass testing in a way, because I think that that we don't have enough evidence yet on the epidemiology or the validity and of any of the tests to understand what value they will have for mass rollout of testing. I think there's some really interesting studies coming out now from all around the world about the prevalence and positivity rates of antibody testing in communities, which seem to vary and perhaps are as high as almost 40% in some countries. And until we really understand the use of testing and the repeat testing, we're getting a lot of pressure to think about repeat testing, but I'm not sure that helps in many ways, because we still need people to isolate and keep to those main messages. Thank you.
Dr. Naima Al-Qasir, WHO representative in Sudan and one of the founder of Arab Public Health Association, asking a practical question, and actually many other people, I'm looking at the screen, ask similar question. What is the validity or actually the usefulness of a finger prick test, fast test? Is it reliable? Should we spend money on it? And how not only reliability, some people talking about accuracy, and the other question, what is the ideal number of PC tests per million that a country should conduct on daily basis?
From my perspective, I don't think we know the usefulness and validity of pinprick tests, finger tests at the moment. In the UK, we've seen a flood of tests come in and people are starting to buy them. The national advice, though, is they're not useful at the moment, and we are really doubtful of the validity of those tests. So certainly in England, at the moment, there are many studies going on to check the validity, but we wouldn't be advising buying them in any significant number at the moment, is my understanding.
I think this is, Andrew, let me stretch this, and I want everyone to contribute to this. Really, this is something we need to stop here, take a stock, so to speak. What you said is extremely valid and based on science. So why don't we make that globally? And all what I see, and we're receiving so many messages across our network and the Arab Public Health Association, people almost showing off, this is what we are doing in country, this is the test is available, this is blah, blah, etc. You know? So why don't we have this global consensus that actually there is no evidence, it is not useful, the UK government advising citizens not to spend money on it. This is what's worrying me about this pandemic. I mean, with all my experience in public health and dealing with many, epidemics and outbreaks, etc., over so many years, not from the academic side, from practical side, like you, Andrew, and other colleagues, But why don't we have that global consensus?
I think that's a very interesting question. There'll be lots of competing pressures on that. Yeah. I think, and this gets to the heart of why we're not doing mass testing in our country. I think I would like to see countries working together. I think the UK has held a firm line, and I suspect that there is much criticism that we should be doing mass testing, and of course, particularly antibody testing. I suppose I'm struck every time listening to the evidence, though, that and regarding immunity, that we don't know. Actually, you could have a negative antibody test and still be immune. You can have a positive antibody test and not be immune. We don't know the proportion of the population who are immune. We don't know how long immunity will last. We hear reports of people having secondary infections. I've seen no evidence to support what is happening there. So I don't think if we were to really take the precautionary principle, I think, which is much beloved by public health colleagues across the world, then we need to be really clear, and we need to fall back and remember why we do testing and why we do screening and why we do epidemiology surveillance, which is all producing information for action. And unless we can take action on the results, we shouldn't be doing it.
Mohanad?
Yes.
I'll come to you, Dr. Mariam, Professor Khoja, I'll come to you. Mohanad.
I'm only watching the time, Dr. Salam.
Yeah, I know. Mohanad.
Just to answer your question, why we do not have this global consensus, I think politics is there. We started talking about this, and we every day see politics around the outbreak. And usually public health is very close to the politics. But as you see, in this outbreak, we are getting more and more every day with politics. So I think this is the only reason. And I think a lot of debate, discussion, because this is a new virus, and I think wherever we see new facts and the studies, we have to follow. It's very complicated, I think, and it's a new situation that it's very difficult to us to do a consensus. Again, politics, Dr. Salman is there.
Yeah, we have 9 minutes. I want to listen from Professor Faris, from Dr. Mariam, and from Professor Tawfik. Professor Faris.
Thank you so much. I will be very precise and concise very quickly. Just to highlight one issue that had been raised in the question about the validity about the rapid antibody testing. In fact, we did, as I mentioned, we did some, we reviewed the data that we already had. We used something like roughly 50,000 tests had been used. And out of this, I remember something like 400, let us say 500 were positive for IgM based on that, out of those 50,000. And this had been all those 500, let us say, we tested them again by PCR, and only 50 of them, roughly 50 of them had been to be really positive. So again, I think this can give very, very rough idea about what is the positive predictive value in this case. It is very low indeed, and this is not helpful at all in making any judgment about the situation. One last issue that I would like also to highlight about using the primary healthcare center for testing. In Iraq, we started first of all with the public health labs and with the hospitals. But very recently, we found that we have to use the primary healthcare center and it should be engaged, but not all the primary healthcare center. Today, we had assigned, and an official memo had been sent to all the governorates that to assign one single primary healthcare center in each district where there should be a capacity for having nasopharyngeal swab and data to be tested in the public health lab, and not to engage all the primary healthcare center, not because, and in this case, I think we are going to expose large number of our health workers for those patients. Meanwhile, it will be overuse of PPEs as well, which again, there is a scarcity of PPEs all over the world, as I know. Thank you so much.
We'll discuss it next week. Dr. Mariam, please.
Dr. Tawfik, please.
Professor Tawfik.
Okay, thank you so much, Dr. Mariam. I really, this question, I am looking, I would like to ask, what is the role of the WHO in this regard? I think this is the role of the WHO, why we should ask the countries to act together. I think we should sit down a working group from all the 6 regions and bring these scientific people from public health, from people who are in the lab and so on and so forth, people in the primary care, expert people together from all the 6 regions, and they should sit down the guidelines for all countries and ask countries, make a resolution as they do for all the other things. So I think that the only platform for such approach, Prof. Salman, is that WHO should has the lead in this regard, and should not wait for countries to act. I think the WHO role in this regard, as when I was in the General Secretary for the Gulf region, our office always taking the lead to help the countries to act together. And so I stress that WHO in this regard still is not in the picture. Thank you so much.
Dr. Mariam?
Yeah, Dr. Salman, allow me to react to Dr. Mohanad's question. Who will analyze all this big data? And I'm sure all of you are aware how advanced is technology when it's come to big data analysis. And what happened with COVID-19, this never happened in the scientific era, where everybody is sharing the data and information in spots with no competition who will publish first. And I believe this was a very big advantage for us in the field of research and academia and clinical and applied science to collect this data. And while we are talking, there is many well-defined center globally trying to come up with all those conclusions, which will help not only how sensitive and specific is the test, but they will go furthermore to know how sensitive it is with relation to the genotype and ethnicity of that particular patient or a carrier, and even the clinical scenario of that a particular human being with infected with COVID-19. And the other point, I believe it's very essential as well, Dr. Salman, to have a proper webinar session where we talk only about the role of a primary health care. Because as I understand, and from a feedback in the region, in United Arab Emirates and other countries, they do have a different criteria and different approach. And I believe they will be the people who can give us the proper feedback and from their experience, and we can hear and listen more from them.
Well, this is really a big question. Why do we have different approaches when the virus is one? You know,
I think it's good, Dr. Salman. It's
this
good.
is a good question.
There is no one size for all. That's what we learn.
You set the scene. You set the scene, Dr. Mariam. I'm really grateful for that. There are a couple of questions. I will raise it in the last few minutes. One is, should we increase testing in countries where they are unlocking and easing the restriction? Another question from Samar about, yes, we fellow contact tracing for symptomatic cases. What's about contact traces for asymptomatic? I'm not sure. How do we know that they are asymptomatic? Need to define their contact tracing. But question to you, anyone from the panel? Carry on.
I will try to volunteer to a little bit. Yes.
We have 3 minutes, Mohanad, quickly.
Yeah, in brief. I think that question belonged to yesterday's debate.
Yeah.
About whether we need to test asymptomatic cases or not. Yeah. And here, there was some discussion, debate about what we mean by asymptomatic, pre-symptomatic and cases, and there was a discussion about the asymptomatic are less likely to affect others. However, yes, today and yesterday, and I was reading one hour ago, ago before contacting the session, this was, still unclear. And this is very debated questions. And the question that we do not have answer for so far, how many of our patients are asymptomatic? And the current literature review shows it between 6% until 40%. And here the question, if we do not want to test this big group, how about the infectivity and how much cases that we maybe have in the future? I think it's debatable, questionable. The disease is new. No one is wrong and right. We need to keep, doing research, as Dr. Mariam said, and to come up with these things. It's
Thank
still
you.
not clear.
Thank you, Mohanad. Thank you very much indeed. On behalf of all members of the Arab Public Health Association, Professor Tawfik Khoja and myself would like to thank you very much indeed, Your Excellency, Dr. Mariam Matar, for chairing this session and enlightening us, for Dr. Mohanad Al-Nsour, and for Dr. Andrew Howe, and indeed my friend and colleagues, Professor Faris Al-Lami, stepping with us in the last minute. Thank you all, and thank for all those who raised the question. Next week, we are welcoming our dearest brother, our Matariya, as well as Ed Kelly from WHO, both in IMRO and Geneva. Have a lovely night and see you next week, if not earlier. Take care. Bye-bye.
Thank you very much.
Bye-bye.
Thank you.
Thank you.
Bye-bye.